Yeah, so along those lines, another curveball for Taufik. So, we have data now that, not now, for many years that, cyclophosphamide is very good at depleting Tregs, and doxorubicin is a very immunogenic chemotherapy. You see where I'm going here. So, we switched from, CAP, Cytoxan, adriamycin, platinum to etoposide largely for tolerance reasons. Maybe we should be revisiting the CAP regimen with immunotherapy.
I would not disagree with that. I believe that as we understand more and more about the biology of this disease, now that we also recognizing that different subset of small cell will respond to different regimen, it would be good to let the biology drive what we do for the patient. So we still know that 30% of our patients will not respond to platinum-based doublet chemotherapy. Whether that is the platinum component or the topoisomerase inhibitor component, we don't know that for certain. But whichever one it is, we know that a third of them will not respond. And the question is there a subset there that we can identify who will respond to the anthracycline-based strategy that we can then offer the CAV as the chemotherapy of choice? That would be a very difficult study to conduct now, given where we've gone with platinum doublet plus immunotherapy. But I think the salvage setting actually gives us the opportunity to answer that question. Because now if we go forward and we sort of move away from topotecan, that gives us the opportunity to look at those patients who are very, very poorly responsive to chemo-IO, and then maybe in salvaging them, we could go back if they have the right organ requirement and performance status, see whether they will be the ones to respond to CAV. And at the World Lung, Lauren Bayer showed some of our data showing that different subtypes of small cell will respond to different classes of agent. Although she did not look specifically at anthracyclines.
I think she mentioned gemcitabine.
Yeah, so that's the direction I think that the field should move.
Even within if you look at the Empire 133 data, the patients, there's about 40% of patients that had liver metastases, and they both arms did fairly poorly. The hazard ratio was still favorable, but their outcomes were uniformly worse. Whereas if you didn't have liver metastases, you seem to benefit from immunotherapy more, and the hazard ratio was far more favorable. So maybe we need to think about that subset of liver metastases and try to figure out a way to do better for those patients as well. And I think one of the challenges with small cells, we don't really know which patients are going to have that durable benefit and which aren't. We talked a little bit about liver, metastases, but in practice, I think it's challenging. Does anyone use, PD-L1 expression or TMB or ctDNA to kind of see what's going on with the patients at all? Jane? No.
The data to date has not shown us a great signal. It's been conflicting, particularly the plasma data. And I don't think we have either the luxury of time in this patient population to make that differentiation based on biomarkers.
Yeah, I think the TMB appeared very promising to start with from the 032 trial, with that 1 year overall survival rate of 62%. But then when we went back to the front line from the Empower study and the blood-based TMB did not seem to predict benefit, it became a little bit more confusing. But I'm hopeful that we don't abandon the attempt to develop biomarkers for immunotherapy in this disease, because it will help the field as a whole. More importantly, I think it will help us help those patients who don't benefit from the current strategy so that we can figure out what we need to do to make immunotherapy be beneficial to them.